So what is coronary artery disease? It's a buildup of plaque in the arteries caused by, due to what?
Like lifelong.
I thought you said Wi-Fi problems. I was like, I didn't say that. I mean, probably is. We don't know, right? 50 years from now. Okay, but what does that mean? What is lifelong problems? What is that?
From a diet.
Okay, so you're saying from smoking, from what kind of diet? Like, give me some information.
Junk food.
Like
High fat.
high fat, high cholesterol diets. Yes. And then all the junk builds up in the arteries. And then what happens? It blocks blood flow to what?
The heart, or the body.
Which part of the heart would it block blood flow to?
The muscle.
So this is plaque builds up in the coronary arteries, right? Coronary artery disease. And then the coronary arteries provide blood flow to the myocardium. Y'all with me?
Yes.
All right, that's good news. I think I'm already kind of annoyed because the session yesterday was not good. Okay, so if I was going to test someone for coronary artery disease, what labs would I run?
The lipid panel.
Okay, so we're gonna do a fasting lipid panel, right? And what's included in the fasting lipid panel? HDLs, LDLs, triglycerides, and total cholesterol. So total cholesterol, we want less than 200. Triglycerides, we want less than 150. LDLs, we want less than 100. And HDLs, we want greater than 50, or some places will say 40. You with? Okay, what tests would I run? Because that just tells me whether they have like risk factors, right? It doesn't actually tell me what's going on in their coronary arteries.
I would do a stress test.
Okay, so we could do a stress test. What does the stress test tell me? She's like, that is all, just ordered it. Okay.
How hard their heart is working.
How hard their heart is working. Tell me, what do you mean by that?
How it can work under like stress, like exercise.
So we're basically going to exercise them, right? And see how well their heart is able to maintain oxygenation.
Yeah.
You see the big girl words we use in today. All right. I feel it. Okay. So if a patient has coronary artery disease, how would I know? Oh, wait, let's go back to tests. Okay. So you said you would do a stress test. What else do you want to do? We could do an echo. What does an echo tell me?
It looks at the arteries with the ultrasound to see.
Does it?
Looks at the blood flow of the heart.
It looks at the blood flow inside the heart, right? So I'm going to look at the valves. It will show me where the blood flow is. It'll show me whether it's oxygenated or not oxygenated. So that's looking at inside the heart. All right. What else do you want to do? What is the disease that we're talking about? Coronary artery disease. So do you want to maybe look inside those?
Yeah.
All right. And how would you do that?
Cath lab.
All right. So we're going to order a coronary angiography. Guys, I might not use this video. Coronary angiography. What does angio mean?
Vein, vessel.
A vessel. And ography, picture, and coronary.
Heart.
So I'm going to take a picture of the,
Heart.
yeah, we got that. Okay, what else do you want to do? You've done a echo, you did a stress test, and you did a coronary angiography, cardiac cath, whatever you want to call it.
Could you check troponin?
Well, that's for an MI, not for CAD. I mean, they're at risk for a heart attack, but if they're not symptomatic right now, then
If they can't exercise, you can give them like atropine to do another kind of stress test.
you can do a stress test that, a pharmacological stress test. You could, yes. What?
That's a bigger word.
Yeah. Okay, there's two different things that the heart does, right? It does mechanical and it does,
Electrical.
oh, hello. So we'll do an EKG, but an EKG is only one small period of time. So if I want to see what it's like over a longer period of time, I'm going to use a,
Is that like a monitor?
Yeah. What's it called?
Holter.
Holter monitor, right? And they will go home, or sometimes they'll admit them, right? There's a telemetry unit in most hospitals. Yes. Okay. Don't you want to see like if the heart is big or small or yes. So what would you like to do? Chest X-ray. Yes. So we get simple. Yes. All right. So we're gonna do chest X-ray, EKG, echo, stress test, coronary angiography. Yep. And we're gonna run some laps, right? Okay. So now I kind of have a picture of what's going on in the heart. Yes. Okay. So if I find out like, yeah, they got it. What are they at risk for when they have coronary artery disease?
Clots.
MI.
mostly an MI, right? Because this is, it's coronary artery disease, right? So this is inside the heart, okay? So an MI,
Heart failure.
right? Especially if they have a massive MI.
Cardiomyopathy.
They could have cardiomyopathies. I agree with that. I love that word. I don't know why. Isn't it kind of a nice word? It's like cardiomyopathy. Oh my God, I'm so smart. Okay. What are the medications you think we would use to treat this patient?
Statins.
All right. So we'll use some kind of cholesterol lowering drug. Statins are an option. What are your other options?
Nitro for chest pain.
Okay. So we can use nitro if they have angina, because coronary artery disease then leads to angina, which will then eventually lead to an MI, right? So we're trying to prevent all that, right? What is angina?
Chest pain.
Chest pain that is cardiac in nature. Yes. Okay. It's where the what?
The arteries are constricted
and blocked, right? By the plaque.
Yes.
Okay. So arteries are constricted and blocked by the plaque, which causes myocardial ischemia, which then will cause a infarction. So you have two different types of angina. You have yes, unstable. All right. So what does stable angina mean?
It can help with rest. Oh, you meant both.
Sorry,
Sorry, I
what?
thought you were just asking about stable.
I am.
Yeah,
It's related to it.
Oh, it gets better with rest.
Oh, I see. All right. So stable angina means the plaque is stable. It's just sitting in there, right? Okay. So it should get better when you rest, because when you're like exercising or doing things, your vessels are going to constrict around that plaque, right? When you rest. What else do we know about stable? You get relief with nitro because nitro is a vasodilator, so it'll give you room around that plaque. Yes. All right. What else?
It only occurs with activity.
All right. So it's predictable, right? So I know if I like get up and I run across this to that park really fast, or just run period probably, then I'm going to have some issues. Yes. Not me personally. I don't want to put it on myself, but you get what I'm talking about. All right. What is unstable angina? It's unpredictable.
Rest doesn't help.
It doesn't get better with rest. It just happens whenever, and you don't know when it's going to happen. It doesn't get better with nitro, right? Now, how do you know that it's unstable angina versus an MI? Because if the symptoms aren't getting better, how would you know? Do y'all see what I mean? Oh, you don't. So what do? You go to the hospital and you say, I got the chest pain. And then we have to do a full cardiac workup, which we're going to go from door to cath lab today. We're going to go through that whole algorithm, which should be a fun time. All right. Do you understand? There is a third type that we've never talked about before. It is called Prinzmetal. Yeah. Prinzmetal. Prinzmetal. This is basically a coronary vasospasm. They have no idea why it happens. It's kind of like Raynaud's of the heart. Okay. Does that make sense? Okay. No precipitating factors really. I mean, it's not triggered by cold like Raynaud's is, but it's basically just like you're hanging out, you're doing nothing. You're just at rest and all this, you're like, oh shit. Okay. Do you understand? That's been on NCLEX a lot. So I've never taught it before, but I'm just pointing that out this time. Okay. So let's go back to medication. So we talked about statins. What are some other, okay? Do you need a Heimlich?
No.
Oh, all right.
Okay.
Then. Do you want me to suction you?
No.
Okay, I don't have one, so that works out. So, all right. What are some other options for cholesterol lowering drugs? Oh, gemfibrozil. Yeah. What else? What? Where are you coming from? Ezetimibe?
I remember the page.
Oh, okay. So at the top was no. Oh, maybe it's different for you. I can't remember. All right, so we got statins, gemfibrozil, ezetimibe, and there's one that you can get over the counter.
Oh.
It's a vitamin.
Niacin.
Niacin. Oh, very good. Okay. So we're gonna put them on that. Okay. Their heart is overworked at this point, right? So what do you think their heart rate's gonna look like? My stomach's about to crawl. I'm already so hungry.
It's overworked already? Is that what she said?
Right, because it got coronary artery disease, right? So the blood has to pump harder, right, to get through, and the heart's like, huh? They're not in Brady, they're in Tacky, right? Because it's trying to pump blood to the heart muscle, right? So what are you going to get?
A beta blocker?
Yes, you're going to get beta blockers, which end in.
Oh.
All right, then. What's our other option? Beta blockers, what's the sister?
Calcium channel blockers.
Okay, calcium channel blockers, and those end in peen plus two randos, which are verapamil and stop that. Okay, should take it back.
What's this button?
D.
D.
Yes.
Oh, the tells them?
Diltiazem.
Okay.
Okay. You're obviously going to give them a script for nitro, and I'm hoping y'all remember all of the teaching that goes along with nitro, right? Sublingual, keep it out of light.
Yes.
Don't put it in your car. Okay.
Yes.
All right. And then if we don't want them to get like a clot in that coronary artery, we probably also ought to give them some
Aspirin.
aspirin.
Baby
Okay. Because it is a antiplatelet aggregator. Good. I'm glad y'all didn't come up in here with a, you know what I'm talking about.
Yeah.
All right. If you're going to give them teaching, what's the diet that you're going to tell them to be on?
Cardiac diet, so low cholesterol.
Low cholesterol,
Low sodium.
low sodium,
High potassium.
low fat, high potassium. Very good. All right. You want them to exercise?
Yeah.
Yes, we do. You want them to control other comorbidities,
Yes.
right? Because what are the leading causes of CAD and MI?
Diabetes.
Diabetes,
Okay.
smoking. So tell them to obviously
Mhm.
stop it.
Obesity.
Obesity. So we want BMI less than
30.
25. I mean, yes, 30, but also less than 25 because let's be like 98. Well, technically you're correct. Okay. Stress is also another big one. So you're going to teach them, stress reduction techniques. All right. So I am going to give you either vital or a lab, and you're going to tell me what your goals are for this patient.
Okay.
Okay. Blood pressure,
120.
less than 120 over 80. Good job.
Well, I'll see those
Hemoglobin A1C, less than
7%.
6.5 is that's a UTB Wisniewski thing, but for like NCLEX and things like that, it would be 7.5. Okay.
Okay.
Total cholesterol,
Less than 200.
triglycerides,
Less than 150.
less than 150, LDL,
Less than
less than 100, and HDL, greater than
50.
50, greater than 40, whatever. How often do you want them to exercise? Exercise goal,
30 minutes a day.
30 minutes a day, 5 days a week. Okay. BMI less than
25.
25, and go get it wrong now. Okay. Y'all did pretty good on that. How you feel about coronary artery disease?
Great.
Okay. So I'm going to walk you through a basic MI, like we're going to do it's called acute coronary syndrome. Acute coronary syndrome is like a very umbrella term for chest pain that we don't know what it is and we got to work you up.
Okay.
Okay. So an acute coronary syndrome means you came in and you said the key word in the ER, which is chest pain. If you say you have chest pain in the ER, what happens?
You do a full work.
That is priority, like where you're coming back immediately, and patients know this, right? So they'll come in and say, I have chest pain. And they're like, oh my God, come right back. So you get them back and they're like, actually, my left pinky has been hurting for about 3 months now. They know. Okay. But if they say chest pain, that is a red flag word in the ER and you have to do a full workup. What is the absolute goal from door to cath lab? We have to do that in less than
An hour.
60 minutes, which we're about to talk about a lot of things that have to happen in 60 minutes. That's why we run in. Okay. All right. So let's do case study and I'll walk you through it. Are you ready?
Yeah.
Can you find are my glasses over there?
No.
Oh no, I can't
For
see.
what?
Oh no. Okay, I'll get it in a minute. All right, but I'll probably be like this. I don't forget where I'm at. Okay. So if your patient is having chest pain, they're going to call 911,
Yeah.
right? After their second nitro, right?
Okay.
All right. So they call 911. EMS comes out there. What's EMS going to do?
Oxygen? No.
I mean, maybe.
Oh.
Y'all remember we'd only place oxygen if their SpO2 is less than 90. That's an ACS rhythm. I mean, algorithm. Yes.
Yeah.
Okay. So they come out there and what are they going to do?
Put them on a monitor.
Yeah. They're going to put on EKG, right?
Uh-huh.
You think that's probably important? Because if we see a STEMI, then we're like, well, shit. Yes.
Yeah.
Okay. All right. So they're going to put them on a monitor. Okay. They are going to put them on it,
Pulse ox.
SpO2 and a pulse ox to make sure that they're oxygenating. If they're less than 90, you can apply oxygen. If not, we're not going to do that because they don't need it. Correct.
Mhm.
Okay. What else do you think they're going to do there?
And they might give them their last nitro dose.
They could give them a nitro dose if they didn't already take it, but they're going to have them.
Do it.
They're going to chew something, but it's not a
Aspirin.
nitro. Yeah. They're going to give them an aspirin to chew. And why would I do that?
Gets them fat. Gets it through the bloodstream faster.
Okay. So it's going to already start the antiplatelet aggregation because if we already have platelet aggregation, we want to kind of stop that. What's the dose?
81 milligrams.
No, you're in an
3.5.
acute coronary syndrome. You're like, here's a baby aspirin. Good luck with your STEMI. It is 325. Yes.
Yeah.
Okay.
Uh,
So they are going to do an EKG. If they see a STEMI, it's like, whoa, let's go. If it's not a STEMI, but they still are like, oh no, they're already going to call the hospital and let them know, hey, we have a possible heart attack coming in, right?
mhm.
Yeah. Do you think they're going to start an IV in there?
Mhm.
Probably. You think they're going to give them some fluids?
Yes.
I bet they probably will. Okay. So then they come to you. What do you do? Ready? Wheel them in. I have a 52-year-old male with chest pain. We've started an IV and an EKG showed normal sinus rhythm. But here, now go.
chest X-ray.
Okay.
Pharyngeal.
So as soon as you, we got to do some other things first. Okay, so patient comes in, you get him back into the room. What's the first thing you want to do? Okay, and how would I do this?
Look at him. Take
First
your
thing you're gonna
vitals.
do, your vitals will never be the first thing you do in an emergency department. Because what vital with an MI could be so horrible that you'd have to like do something. Okay.
I would do
First thing you do when they come back.
I would do labs.
I would not.
Put them on our EKG.
Okay, so we're gonna put them on an EKG. Are y'all okay?
Well, we said that.
You didn't.
Oh, I said that.
Oh, I didn't hear you. Sorry. So we're gonna put them on our EKG, right? So you have to switch over monitors. Anytime they ask you when you have a patient coming in, the first thing you do is to put them on a monitor. Okay. And that will be across the board. When we do trauma, we do all those things, it's a monitor because they're gonna have them on their thing. And just because he was normal sinus rhythm 15 minutes ago does not mean he is now, right?
Yeah.
Okay. So you get them on your monitor and you find that there is an ST elevation. You want to do something now, or what are you thinking, or how you feeling? Okay, well, he's rapidly dying, so you call the doc. He don't care about you. Okay, if there's an ST elevation, what does that tell me is happening? He's having a STEMI. So is he having an active heart attack? Would y'all like to do something about that?
Yeah.
Okay. So we're gonna get IV fluids running, right? You can put him on a nitro drip, right? Do you want to maybe help him with the pain or something? Because he's probably like, oh, something's sitting on my chest. Okay, what would you like to give? Do y'all not remember Mona?
Yeah.
All right, so we're gonna give IV push. Sorry, I can't always hear everybody at one time. Oxygen only if their SpO2 is less than. Okay, we're gonna do nitro drip because at this point the sublingual is not effective, so that's really not gonna help, is it?
No.
If they haven't already had the aspirin, you can do that at that time. You with?
Yeah.
Make sure they have IV access. So if EMS did not do it, you need it because this patient could code at any second. Yes? All right, what else you want to do? And hurry up. You said it earlier.
Chest X-ray.
Now we want to get a portable chest x-ray. That needs to be done within like less than 30 minutes of them coming in. Okay. Because I need to see what's going on in the heart. And you're about to do a coronary angiography. Like, great, they're going into cardiac cath and I need to see their heart before I do that. Yeah.
Yeah.
Okay. Now we can run. Yes. Okay. So what labs y'all want to run? All right. We're going to run a troponin.
BNP.
BN or BM.
BN.
Okay. BNP.
Type in cross.
We're gonna do a type and cross just in case, you know, in cardiac cath, they, yeah. Go on. There's about 15. So, and give me a rationale for each. Okay. What is a BMP?
Basic metabolic panel.
And what does a basic metabolic panel do? Electrolytes. I need to know because this could be sodium, potassium issue, right? Heart things, weird heart things can happen. Yeah. Go on. MB, CKMB. So we did a troponin, CKMB. What are my other cardiac enzymes while I'm running those? It's not a cardiac enzyme, but I will run a D-dimer because a lot those symptoms can mimic a PE. And I'm only doing a BNP because I want to rule out heart failure, right?
Yeah.
Y'all know that. Okay, so give me but I just want my cardiac enzymes for MI. That's what I'm asking y'all.
Okay.
So troponin, CKMB. We'll run a plain CK, right? Okay, because that will just tell me overall like muscle inflammation, but it does occur usually earlier, so I may be able to catch it. Okay, go on. What's a byproduct of muscle breakdown?
Lactic acid. No.
Well, yes, you could, but that's not the main. What's the other one? Remember, we've talked about this probably 50 times. I said there are two byproducts of muscle breakdown, and everybody goes lactic acid. And I'm like, what's the other one? And then it went like this.
Because isn't it like rhabdoid?
Yeah.
Myoglobin.
Myoglobin, that's another one that we're going to do. Now, which ones of these are, oh, there's an LDH too. LDH, okay? Not LDL, LDH, which I'll talk more about in a bit. But which of these are specific to cardiac? CKMB. Try again. Go ahead and just say it. CKMB. Yeah, creatinine kinase myocardial bands. That's what that sounds for. So it stands for. CKMB and troponin are the only ones that are just for heart. The rest of them could be caused by inflammation from other places or muscle breakdown in other places, but we still run them, and I'll tell you why. Now you're going to keep running serial enzymes. Why do I keep running them like every hour or so?
Because they could change and get worse.
They can change, and it will tell me too, based on, I have a chart for you guys, so don't panic. It will tell you each enzyme rises within a certain amount of time and goes down in a certain amount of time. So it'll tell me exactly how long that this patient has been without blood flow. Okay.
Okay.
Okay, so you did that. Cool. So you've got a nitro drip going. You gave them morphine IV push. What is the morphine IV push for?
Pain.
And it's for pain and the other big giant reason we give it. It is a vasodilator of the coronary arteries, right?
Yes.
So we're going to kill two birds with one stone. Yeah.
Yes.
Okay. So we are going to repeat the EKG. All right. And I'm going to do 3 different scenarios. Okay. When we repeat the EKG, we find that the patient has normal sinus rhythm. Are they having a heart attack?
No.
I don't know. You know, people can be in normal sinus rhythm and still be having a heart attack. So you can't just be like, well, it looks good. Take care. Yeah. So remember, they do not have to have a STEMI. There's also a non-STEMI. And sometimes they're in normal sinus rhythm for a while before we actually see any changes. Okay. Okay. So if it is normal sinus rhythm, okay, then we're going to keep watching.
Mhm.
Don't you think we're going to run some more cardiac labs? Okay. So we'll do the enzymes to see, is this changing? Yeah.
Yes.
Okay. And then we're going to look to see if the troponin is changing. That's the big one that will change if they're having an acute MI. You with?
Yes.
If all of that looks normal and they continue with normal sinus rhythm, then we're like, hey, this was probably unstable angina. The Motrin, don't give that. The morphine and the nitro probably really helped. But we need to send you obviously to your PCP because that was kind of scary. Okay. Y'all with me at that scenario? Okay. Let's change the scenario. And the patient has ST. The patient, I mean, that was long. The patient has ST depression. What does that tell you? Okay, so there's some type of ischemia. So we got it early, but we got to act fast or they're going to be having a full out heart attack. So what do you want to do for this patient? Oh, we got other stuff we got to do first, right? Because I need to know how quickly I need to get them in there and what exactly I need to do for this patient. So if they're high risk versus low risk, I'm going to do something different. Okay, what would make a patient high risk for an actual MI? Okay, what could I see in my patient that I'm like, oh no, this is kind of shitty. And like, even though it's not showing quite yet, like on the EKG, this is probably not that good.
Would it be like lethargic?
No. Ask this in a different way. But if they had comorbidity, I would expect that, right? Because that's what happens when you get CAD and then you get angina and then I'm going to put them at a higher risk, but I'm looking at this patient at this period in time. Right now, as they're sitting in front of me, what would I see in this patient that I'm like, I don't know. It's not symptoms. You're actually looking at the assessment of your patient, What would tell me this patient is not stable and I probably shouldn't send them home. But we send them home with high blood unless they're in crisis, huh? Okay, I can agree with that because that would mean that they are somehow hemodynamically unstable, right? So they're having signs of poor perfusion. Now, why would they have signs of poor perfusion with an MI?
There's a blockage somewhere so the cardiac output is decreased.
But the coronary artery is on the outside of the heart, right? So the heart muscle isn't getting perfused. Okay, follow that through.
So it's not.
Oh, what's that called? So they're going into heart failure because of an MI. I probably wouldn't send that patient home, right?
Right.
And a lot of patients that are having an MI or even having cardiac ischemia will end up going into VTAC. If they're in VTAC, right? What's the first thing you look for?
Check for pulsating.
Signs of poor perfusion, right? So I probably wouldn't send that patient home. Okay. So if you see that they are in VTAC, they're hemodynamically unstable, or you can't get the chest pain under control, which means this is forming into a big MI. So if you have a nitro drip and a morphine drip and they're still like, oh no. Do you understand what I'm saying?
Yes.
Okay. So if they look like that or have any of those symptoms, heart failure symptoms or in VTAC, like things that I'm like, this patient is deteriorating. I'm just not seeing it on an EKG yet, or it may not be showing up in the cardiac enzymes. Okay. What do you want to do for this patient? Would you give him something for the contractility? Not at this point in time, because I'm trying to get him in a cardiac cath.
I'm talking about like diagnostics and that, or just anything.
What's your plan of care for this patient once you see that they are hemodynamically unstable, or they might have heart failure, or we're looking at some dysrhythmias? The doctor doesn't care about you. Okay, this is all on you, y'all. This is an entire protocol that you guys are responsible for doing. The doctor will not see you until you go into cath lab. Okay, so you are on your own, which is scary because y'all don't know what to do. Oh, Jesus. Well, but I can't do interventions on the hemodynamic instability at this point, right? What's a big risk at this point for this patient? What are some complications that they could experience based on how they're looking and what's going on here? Huh?
Hypoxia.
Okay, maybe. Okay, let me just go through the algorithm and then we'll play with it again. Okay.
Okay.
So I'm going to give them some heparin. Okay. Because the risk of clotting at this, yeah, is going to be very extreme, right? Now, this 325 milligram aspirin is a joke, right? So I'm probably going to give them some clopidogrel at this point. Yeah. Okay. And then I need to get them into cardiac cath after I've already drawn the labs and all of that. They need to get into cardiac cath immediately. Okay. After cardiac cath, they will be admitted onto the unit. Yeah.
Yes.
Okay. I think I'm going to follow that through right now. Once you get them onto the unit, they're going to go into ICU. Now it's up to you. Okay. So the patient comes in. What's the first thing you want to do in the patient? You get admitted.
Monitor.
All right. So I'm going to put them on my monitors. Yes. Okay. I'm going to have some drips running. What are the drips that I want to have running? We're going to have a nitro drip. We're going to have a morphine drip. We're going to have a heparin drip. Yeah. They're going to have aspirin that's still on the MAR. That's obviously not a drip.
Yeah.
So, okay. I'm going to try to get them hemodynamically stable based on that. What are some other complications in the ICU from an MI? They're not having an acute MI anymore, right? They went into cardiac cath. They did their thing. Okay.
The heart failure.
They could go into heart failure, right? So how would I know? We're going to do BNP, but as a nurse, what's my assessment that I'm going to do that I would know they were going into heart failure? Maybe edema. Crackles is the big one. If they start having crackles, fine. I'll call the doctor on that. Okay. Because what's the other big risk? It's not heart failure. Sometimes takes some time to develop. What's more common in an acute, like an ACS, acute coronary syndrome. That's faster than heart failure. Or the hardest shit.
Nope, sorry.
Okay. Well, here we are.
Stroke.
Y'all know heart failure takes a little bit of time. You can't just be like, oh, damn, they went to heart failure, right? So what's the major heart issue that can happen really fast? Okay, that's fair. Dysrhythmia is fair. But what I'm looking for is we were talking about like edema, right? We were talking about this patient could go bad really fast. This is why they're in the ICU. I'm trying to prevent this issue, huh? Y'all get all the clots. They're on a heparin drip, so y'all can just get off clots. We are looking at the heart. And I know you know it. I'm just waiting for you to. Hello. Is their heart working very good?
No.
Oh. So is it pumping real good?
No.
Oh. So getting a lot of cardiac output?
No.
Oh. Cardiogenic shock.
I said
Wake
shock.
up. I can't hear you.
I said
Cardiogenic
so
shock.
loud. I said
Yeah,
shock,
sorry.
And then you moved
Oh,
on.
I thought you said shit.
No, I said
Okay, I
shock.
thought you were cursing. I'm
I
sorry.
heard
Yeah,
I didn't even acknowledge it. Oh, yeah, I
I
did not hear that. I really thought you said shit. And I was like, well, she mad.
That's why I wasn't
Okay.
thinking about brain anymore.
All right. So cardiogenic shock, that's going to happen faster than heart failure. Now, could they go into heart failure? Sorry. Yes. Okay. But that's going to take some time because that heart muscle would have to die. And y'all see what I'm saying?
Yes.
Okay. All right. So we're going to do that. So we're going to put them on statins, obviously, at this point. When do you give statins?
At night.
At night. In the at night. Okay. Now they're probably going to have some extra fluid. We've been dousing them with fluid and the heart isn't pumping super great. So we're going to give them.
Or albumin, then Lasix.
Okay. I don't disagree with y'all, but we're in like critical care. This is the highest level. So I want y'all to critically think a little bit more. If you're trying to prevent cardiogenic shock and you need to get rid of fluid on the patient, what's more likely for you to give?
It's not albumin.
No.
Okay, let's say well, let me say it one more time.
Do you understand what you're trying to do? You're trying to prevent cardiogenic shock. So how would I prevent cardiogenic shock? What is shock?
Perfusion of the kidney.
All right. So we're moving. Okay. The purpose of what you're trying to give is to pull fluid to the kidneys and get rid of excess fluid. What drugs are really good at doing that?
Not diuretics.
You could give diuretics, but there's a drug that is much better, and y'all know it. It's also good at preventing shock. People get it all the time. No, this is something that people are on, like, they're walking around on it.
It's a cardiac drug.
No. That millions of people take every day.
Oh, Rose?
Yes, we're going to give ACE inhibitors. Now, why am I giving ACE inhibitors? They pull fluid to the kidney. It's not as strong as Lasix. I don't want to put a lot of pressure on the kidneys. That's what Lasix is like, nephrotoxic, right? You remember ACE inhibitors are really good for diabetic patients, right? Because they pull fluid to the kidneys and make sure they're staying perfused, but also help you get rid of fluid. Yeah. If I can't give ACE inhibitors, like who cannot have ACE inhibitors? Because of angioedema.
Asthma patients?
Oh, African Americans.
African-American patients cannot. So if it is African-American patient in ACS, I'm not going to give lisinopril. I'm going to give
An ARB?
an ARB, and ARB's end in Sartan. Okay. So I'm going to do that. Okay. And then you're going to just really monitor this patient very closely. Are you with? Okay. Now I'm going to take it backwards. Let's say that patient came into the ER. We ran the initial labs. Okay. Now we're running. Right?
Yeah.
We're going to run a repeat EKG. And let's say we see a STEMI. Oh no. What are you going to do? That means they're having what? An acute MI right this second. So what are we going to do?
Nitro drip.
They're going to do, yeah, a nitro drip,
Morphine drip?
morphine drip,
Oxygen.
oxygen,
Aspirin.
aspirin.
325.
What?
I said 325.
Oh, 325. I don't know why, like, we're having a language barrier today. I don't,
Chest X-ray.
we did chest x-ray,
Fluids? IV?
IV fluids.
Echo.
We don't have time.
Labs?
We did labs.
Cinema.
Not so fast. When they're having an acute MI, what else do they need? What is an MI?
Myocardial infarction.
And what is that?
The muscle is
Oh.
down. Heparin.
Okay, well,
Clopidogrel.
oh, okay, let's back up. There's something better that we can give if they're having an acute MI. TPA. We are going to go through the contraindication list. Y'all need to go over that from whatever module I did that with you in. The contraindication list, you're going to go through the checklist, make sure everything is okay. You only have how many hours to give it? 4 hours. So we have to use our cardiac enzymes to make sure that it's been less than that period of time. Because people could have been having an MI way before they started symptoms. Okay. And then we're going to keep running serial enzymes. And then we have very short period of time to get them into cardiac cath lab. Are you with?
I have a question.
Okay.
If you give them TPA, but they're going to cath lab, wouldn't they like be at a very high risk of bleeding?
Yes, they would be at a very high
But
risk of
you'd
bleeding.
still give the TPA.
Well, our other option is to let them die. Right? Because they have a giant clot that's killing their heart muscle. So true. Yeah, usually we hold the heparin and warfarin until after cardiac cath. But if this patient is experiencing an acute MI and they have no oxygen going to their heart muscle, then that's what we got to do. Okay. All right. Do you understand the algorithm?
Yeah. I think it could have gone worse.
It could have gone worse. Could have also gone better. Yeah.